So, hello together. My name is Marie-Luise. I'm from Zurich in Switzerland, and I'm here today to talk with Dr. Mazzucco from the University of Oxford about the results of her study, Determinants of Prognosis of Cryptogenic Stroke in Patients with Patent Foramen Ovale. So, Sara, can you explain to me what you set out to do in this study?
Yeah, sure. So, basically, what I'm going to present is some data from a population-based study, which is the Oxford vascular study, and from a systematic review pulled together in a meta-analysis and in a meta-regression analysis on the impact of age and of PFO size in prognosis after a cryptogenic TIA or stroke in patients with PFO who are, importantly, on medical treatments alone. So that's the group of people we're focusing on. And if you want me to talk about what we found, which is really interesting, is that indeed age is a determinant of the risk of recurrent stroke after these events, in that it does increase steadily with age. And this is very apparent in the meta-regression, where it's very clear that the risk of recurrent stroke in these patients is very different at the older spectrum, end of the spectrum, of the age spectrum, as compared to younger patients. And you know, younger ages is very much where all the studies and indeed the trials on PFO closure are clustered between 40 and 45 years of age, and the risk in that area is really low, is below 2, whilst at the other end is nearly 3 times higher. So in the older population is much higher. And interestingly, someone might argue, well, this is just because with age, all the background risk factors for stroke increase as well. And so this is just a specific increase in risk and in risk of recurrent stroke. But actually, we did show that by comparing patients with PFO versus patients without PFO stratified by age, the risk of recurrent stroke is only increased in those patients with a PFO and older age. So there is an excess risk which is age specific and related to PFO. Mm-hmm. And then as to the other component of the study, so the PFO size, that's less straightforward. So in that there is quite a lot of emphasis around the concept of high risk PFO, which is supposed to benefit most from PFO closure, for example, and which is either a large PFO or a PFO with an associated atrial septal aneurysm. But the two components of these are hardly ever analyzed separately in the literature, which is what we try to do. And not very many studies reported this specific analysis, so numbers are small, but in the meta-analysis, there is just a hint that risk is increased for larger PFOs. But again, numbers are small, and there is quite a bit of heterogeneity. And there is also quite a bit of variability in the proportions of numbers of large PFOs versus small PFOs that are enrolled in each study, which does really vary quite a lot, suggesting that there might be some bias in the way patients have been selected in some of these studies. And this clearly requires a bit more research and doesn't really allow us to draw any conclusive assumption.
So I think that's really an interesting study, as you already mentioned, given the fact that the PFO closure to date is only recommended in younger patients.
Yeah.
So we do not really know much about the impact of closure in older patients because we do not have any randomized controlled trials. So my question is, how many total events did you have during follow up in the study?
Yep. So overall, so counting both the Oxford vascular study results and the pooled analysis from the systematic review, we got to 268 events during over 360,000 patients year of follow-up, which of course is there were quite a few big trials contributing to this study, so numbers overall are not too small, but numbers were definitely much smaller for the subgroup of studies which were included in the analysis by PFO size. In that case, there were only 7 studies included, with a total of events of 97 events. So numbers get definitely much smaller when we look at this specific element of the study.
Okay, yeah. And especially in the older patients, paroxysmal atrial fibrillation is often present but not diagnosed. Do you have any information which investigations were performed in case of recurrence?
Well, that again varied quite a bit. So, for example, the Oxford vascular study is not really representative of what is done in normal practice, or even what is present normally in the literature, because it's a very thorough kind of assessment, and patients get reassessed very thoroughly for recurrent events as well. But again, that is a source of big variability. And as we know, even for the index event, thorough investigation for paroxysmal atrial fibrillation is quite sparse and not very common, which is in itself an interesting thing, pointing at the fact that maybe that is an area that, well, definitely after the ESOWSO study results, for example, we know that that's something that needs to be investigated more.
Okay, and very interestingly, the topic of high risk features of a PFO is widely debated. We have totally different results in different study. Have you an explanation for these divergent results, or can you imagine what could it be? Is it a problem of examination?
Yes. So, all we can do is hypothesize a scenario, but when it's very clear from the meta-analysis we've done that there is this big variability among studies. So we range from studies that have a very small number of small PFOs and a big number of large PFOs to the complete opposites. So studies where the number of small PFO is predominant, and there are very few small numbers of large PFOs. And of course, there is when you expect a certain proportion, which is reasonable, and we know that probably larger PFO should be less than half of the PFOs, and then you realize that in a study there is a predominant number of large PFO. You kind of suspect that maybe there is a reason why these patients were treated medically rather than, for example, through a percutaneous intervention. And you suspect that they might be, for other reasons that you don't really know, at lower risk for another on another level. And this is very, this is very important to highlight, because it could overall lead to an underestimation of the risk in these patients if that's not accurately, investigated. So although I do not have an explanation for this variability for each study, I do suspect that it is meaningful, and it is definitely worth further investigation.
Okay, and so what do the results of your study implicate for future research, and how can we translate them in our clinical practice?
Well, I think it's very important, because historically, especially from the age perspective, historically, for many reasons, research around PFO and stroke has focused on the young population, neglecting the old population, which is where most of the strokes and of the events occur, actually. And it's left us with no real good data on how to manage this population, which is probably the most relevant to our practice. And I do think that we need more good evidence on this population, and this will be only achieved if we keep including in trials only not just young patients, but older patients as well. And this is why that means that we probably really need new trials, including older patients, and probably including different strategies, even of treatment, even from a medical point of view. So far, not much can be said, for example, regarding the comparison between anticoagulation and PFO closure. So that is another element that needs to be included in further research. And I think we have shown, by just extrapolating data taken from the younger population into the older population, that's not going to be good enough.
Okay. Yeah. So thank you very much, and
congratulations
to your study.
Thank you very much. Thank you.